Hi, everyone. My name is Nicole Trexler.
This is Elena with Public Health. We're going to introduce ourselves and then get into the anti-stigma training. So some of you may know me. I used to work as a first responder. I answered 911 in Dayton and Montgomery County, and then I went to Yellow Springs. So I have a background in kind of being that first response, working with police officers. And then I moved to TCN Behavioral Health, where I'm now a care coordinator. I do assessments, therapy. The big thing is I do the quick response team. So I do post-overdose response and follow-up. And this is a piece of my grant that has been keeping QRT alive. So I'll pass it to Elena.
I'm Elena Romer. I'm the harm reduction health educator here at Greene County Public Health. So anything regarding naloxone, I run the Project Dawn program. So getting naloxone out to the community. And then I also coordinate safe trade along with two other peer supporters that are here at the health department.
All right, we're going to jump into the anti-stigma training and we'll kind of go over the purpose of this, why we are having you watch this, why it's important to what you do, and how it can actually help you in your job. All right, so this is our evidence-based anti-stigma education. It's adopted from NACCHO, which is also connected with the CDC. And this is part of our partnership between TCN and Public Health, again, with that grant that's been funding QRT for the past year or so. So first off, we just want to give a big thanks to you as first responders. You guys put your life on the line every single day. You do a lot. I remember what it was like, let alone, I wasn't on scene. I was behind the phone or behind the radio. So you guys actually are seeing and firsthand experiencing trauma, traumatic events, difficult calls. Sometimes you have really great calls, but I know those can be few and far between. And oftentimes burnout is imminent if we're not taking care of ourselves, if we're not mindful of what's going on. And we can also have frustrations with frequent flyers. I know there's been times where maybe you go out on an overdose at a house, 10 minutes later, you get called right back out, or maybe later that night or the next day, and you're wanting to hit yourself over the head because you're like, what are we not doing that is causing this to continue? Or what is this person not getting that is causing them to continue using or to continue calling? And we can get frustrated by their poor decision making. But we also have to remember that when we talk about addiction, this is chemicals in their brain that tell them that their substance of choice is more important than anything else. And this can include their children, eating, drinking, housing. And that's why we see a lot of people struggling with addiction who've gotten their children taken away, who look emaciated and very, very sick, who are homeless. So just knowing what you guys deal with, what you see every day, we want to thank you and are really appreciative that you continue to show up for our community.
One of the most important components of reducing stigma is just having your own emotional energy to be compassionate towards those that you're helping. And so just a little reminder to do some self-care and institute some professional and personal boundaries that can help protect you against that compassion fatigue and burnout that Nicole was just talking about.
All right, so our course objectives today, what we're going to go over, we're going to define what the word stigma means. I know some of you have already heard this word, may already have your own ideas about that. And we'll explain how it impacts those struggling with addiction when we are actually stigmatizing them by using certain languages, certain behaviors towards them. And these are unconscious behaviors. We're not purposefully being malicious when we're stigmatizing somebody. We're not trying to make their life more difficult. We're not trying to make a call have a difficult outcome. But a lot of these are what we call implicit bias. They're unconscious things that we have developed, whether that's just our culture, whether if it's because we've been jaded by certain experiences. But we'll go over that more in depth. We'll also go over how to recognize stigma and how to differentiate stigma from fact.
So before we get into it, we have a brief pre-test. If you wouldn't mind pausing this video, scanning the QR code, and taking the pre-test. it's a part of the grant funding that we collect pre-test and post-test information just to ensure that the e-based training is good and we're getting some benefit from it. Thank you for taking the pre-test. Appreciate it. So just a little bit of background on stigma in general. Just throughout history, people have been labeled and stereotyped, discriminated against for a wide variety of reasons, whether it was for disability, personal characteristics such as sexuality or race, ethnicity, and also just different group affiliations, religious, other organizations, things like that. And in the mental health and substance use disorders, they have a long history of having being stigmatized. Any sort of mental health issues, people like way back when would consider them witches or possessed or some devil aspect to it. So there's just a long history of people that struggle with mental health and substance use disorders being stigmatized.
So usually we would have a brief discussion when we're doing these trainings in person, but maybe just something to reflect on as we go through these slides is, how do you define stigma? I know for me, I define stigma as that unconscious bias that might fuel the words I use or the way I interact. Even my body language towards somebody may be a part of this unconscious stigma I hold. So just think about how you define stigma, how you've seen it, examples you might have seen in your work, and even not just within the police department or within yourselves, but we often see stigmatized populations stigmatizing each other. So there's a lot of examples of that. I know in my work, I've seen people who struggle with alcohol use kind of talk about those who maybe are addicted to fentanyl will say, well, I'm not a drug addict. I'm not like that. It's just alcohol. That's, addiction is addiction, whether it's gambling, whether it's alcohol, whether you're those people, right? When we see people who struggle with alcohol use, stigmatizing those who have gone down the spiral of homelessness, of intravenous use, and we're not those people. So that's an example of a group that is already stigmatized, perpetuating that stigma within itself.
Actually defining stigma after reflecting on your personal definition of stigma. Stigma occurs when people think or act negatively toward another person or group of people based on specific identifiable characteristics, traits, or affiliations. And stigma contains multiple components and processes that occur both individually and at the societal level.
So there's 6 components of stigma. One would be labeling. This would be when people distinguish a human difference as important or give it a name. So we often hear these labels: lazy, addict, mental, crazy, psycho. Those are harmful labels that sometimes we give, again, not wanting to be malicious, but it's something we've picked up. And what we do when we give these people their labels is we're saying, this is all you are. Your entire existence is now summarized in this one hurtful label. And we have our own labels that, police officers get called or therapists get called. So it's not just the populations we're helping, it's also we've been stigmatized too. So thinking about how we feel when we get called those names or those labels and just kind of thrown into this little box. Stereotyping, we're pretty familiar with this. So when beliefs of a cultural group connect labeled individuals to negative characteristics. So this person is only good for this, or because they look this way or act this way, they automatically engage in these behaviors. We kind of make these assumptions that are hurtful and often incorrect. Number 3 is cognitive separation, when those who are labeled are seen as different from the normal people. So those people, we're not like them. It's a very us versus them mentality.
So number 4 is emotional reactions. Emotional reactions felt by both those that are doing the stigmatizing, such as fear, disgust, or hatred, as well as those that are being stigmatized, shame, guilt, not feeling worthy. And I think that this is probably one of the biggest negative repercussions of stigma, especially those struggling with mental health and addiction, is them self-identifying as those specific labels and thinking that they're not worthy. Number 5 is status loss and discrimination. So when those who are stigmatized, they feel less valued, kind of as I was mentioning, compared to those other members of society. And then number 6 is power. So this extends beyond just individual to more social, economic, or political power that's required to make these stigmatized components harmful to those who are stigmatized. So when it comes to like applying for jobs, if you have a history of substance use or abuse, then they could be less likely to get accepted for that position. So things that are at a much macro scale.
So now that we have a background of stigma, let's dive deeper and look at the different categories of stigma and the impact it has. These are 3 of the most common categories. We can internalize stigma. So this would be, me being a therapist and being like, wow, maybe I am a quack. Maybe I don't know what I'm doing. And giving that self-doubt from a place that comes from this external stereotype that's been put on me. And this we see in the mental health and substance use population is I am not good enough. I don't deserve treatment. I don't deserve to succeed. It often leads to a lot of self-sabotage is what happens. Then we also have public stigma. This would be a community. We don't want those people in our church. We don't want those people to come to this school, right? So we're kind of excluding people. And a good example of this is we actually saw this when the bus lines came in Beaver Creek, right? We don't want the RTA coming because of that group of individuals. Not saying how it was implemented was perfect, how it's been going is perfect, but instead of something that was based in fact, we made these assumptions about what was going to happen because those people were coming into this area. So that's an example of public stigma. Structural stigma, this would be stigma elicited by institutions and policies. So a whole government organization, whether it be city level, local level, federal level. We see these in laws and legislations. We just got fentanyl test strips legalized. Those policies before, do we know exactly how they were born? Probably not, but I would venture to guess that the reason why fentanyl test strips were made illegal may have been due to some sort of stigma.
So the evidence for stigma change. This figure, and you can pause the video and go deeper into it if you'd like, but it basically shows stigma terms and gives examples of how the 3 different types of stigma that we just discussed, the internalized, the public, and the structural, apply to people with mental health and substance use disorders. So it lists different actors whose interventions can target each different type of stigma. So trying to offer some solutions to all these 3 levels of stigma. And so briefly, if you go to the public stigma, some interventions that are offered is just education, to the public, and empowerment strategies, as well as peer support. And I think that's something that's really been increasing more in the health department. We have 2 peer supporters that have lived experience in these worlds, and just recognizing the value that they add to our organization.
Again, one of these discussions that I'll just let you ponder, or you can pause the video, you can just keep it in the back of your mind, is can you provide an example of a situation that demonstrates one of the types of stigma that you've seen in your work? I know there's a million calls I can think of where maybe I hung up a little too fast or got a little certain way, or maybe I heard it over the phone between two individuals where I'm like, what are you guys doing? We're trying to solve a problem. And it's really about attitudes and behaviors when we're interacting with people and when we see the public interacting with each other.
So, why are we ultimately learning about stigma? Experiencing stigma can have a significant negative impact on a person's quality of life and equal opportunity. And so, we've kind of talked about this a little bit, but it can affect their self esteem, their mental health. It creates different barriers to not seeking treatment because of that lack of feeling worthy of treatment, or because they've been called these things for so long, have internalized that stigma and don't think that it's possible for them to successfully make it through treatment and into recovery. So, some four things that impact that stigma has impacts on those struggling with addiction are the not seeking treatment, treatment inequity, as well as just mental illness and health inequity.
So I need you to hear this when we say that potentially stigmatizing people, assigning them those labels, acting on the stereotypes we may unconsciously hold can prevent our callers, our reporting parties from getting the help, which then contributes towards a higher call volume. It can contribute towards worse call outcomes. And we'll go into that here in the next few slides. But this is super important that this directly affects what you do as first responders, what I do as a therapist. And I have spoken with clients who have said, I didn't really get help because I didn't know where to go. It was intimidating for me. I didn't really think I was worth it. What's the use? And this is a result of many factors, but stigma, I believe, is truly one of them. Like I said, more severe calls for service. So if we're having people escalate within the call, maybe we slipped a label that we didn't mean to, or they can sense in our body language that we're judging them. And think about, where is that coming from? Why do I feel this way about an individual I've never met? I don't know anything about them. And I've had people kind of look at me and been like, I know you're judging me. And I have to sit back and be like, you know what? I'm sorry it came off that way. I'm really trying to help you. Now that's with someone who's in a rational state of mind, but think about your EDPRs when it's already escalated when you get there. And if you're walking on eggshells as soon as you walk into that scene, you've triggered them with a phrase or a word you've said, you've made one misstep and it just causes things to escalate. Not saying that, we can read people's mind and figure out what's going to trigger them, but we can do everything in our power to try and present as neutrally as possible and from a place of empathy when we're reaching out to people, so we're not escalating these calls for service. I know many of you have endless frequent flyers that call 911 over and over and over again inappropriately. And this would be because maybe they don't feel worthy of going to treatment. TCN has a crisis line. We've got 988, which is a national crisis line. Sometimes because they've misused 911, now they feel like that's the only place they can get help, but they don't have the confidence or the clarity to go to these alternative places. And that comes with you guys encouraging them to divert to the appropriate resource, call the crisis line if this is non-life threatening, get hooked up with a therapist or a case manager. We're here for criminal matters, we're here for life threatening. We need to make sure that we're diverting people to the right path. Kind of again with severe calls or more severe calls for service, poor call outcomes. Maybe we weren't able to connect with that individual and have a good heart to heart with them, link them with the resources. And you guys don't have to be the resource experts. I want you to know that I'm not asking you to be perfect, to be therapists, because you guys already are pretty much your neighbors, parents, therapists, your lawyers. I mean, there's so many roles that you all inhabit. Just know the right people and empathize with your callers so that they're more likely to get to the right people. Just like frequent flyers, we've got system cyclers. If any of you have worked in corrections, there are some people who probably live at the ADC or the Greene County Jail or wherever more than they live at home. And these are people that are repeated overdose, frequent hospital visits, generational incarcerations, grandpas, dads, sons, grandkids going into jail because it's just this cycle. When we consistently act on stigmatizing behaviors, it really limits our professional growth. We're not being the best individuals we can be. We're not doing our community a service by limiting ourselves. So just being aware of our behaviors and how we can improve only leads to good things, in my opinion. Yeah, and it also fosters a supportive work environment, which we can all use more of for sure. All right, so we are going to play you a couple videos, and keep in mind some of these, it was hard to find some that weren't already using stigmatizing language. Some of these would say addict in them. I get mixed reports from people who do struggle with drug use on the term addict. So just keep your eye and ear out for stigmatizing language, but these were the best example of what I was trying to show you guys and get a look into kind of real life examples of this stuff. So ignore that and just sit back and watch these videos.
As the heroin epidemic has spread, cities and states have grown desperate to come up with solutions. Here in Seattle, beat cops are 4 years into a radical experiment to deal with drug use on their streets.
Oh, cops. I hate that. Don't you? Hey, I want you to do me a favor. Do me a favor. Stop moving. Stop moving. Okay, good. Because when you're moving, I don't know what you're doing. I get. Okay, when you stop moving, I got you. You're getting well. Not a big deal. All right, I'm not gonna jam you up. I just, we gotta find out who you are. Okay? Cool.
The girl on the ground just is getting well. She's shooting heroin.
Stop crying, babe. We don't care.
These officers are making fewer arrests. They are more likely to refer addicts they encounter to social services.
Where's the syringe? Because I want to be safe.
So you've become a social worker.
We are social workers.
You are social workers.
Yeah.
But
yes,
viewer
how many
listening to you now would
Yeah.
say, gee, you're taking an awfully
Bleeding heart.
gentle approach.
We could not incarcerate these people or arrest our way out of the problem. You would arrest a person, they'd be in jail for 20 or 30 days. They would get sober, they would start using again. We continue to arrest them, and then they would use and continue to arrest.
How much do you use a day?
Like $5.
Okay. And how long have you been using?
I just got out of jail.
I'm not putting you in jail. Are you a meth user too? Do you have any desire to get on methadone and get well?
That's
or
what I'm trying to do.
If you have a problem, come and see me at this office. I'll give you something to eat. I'll let you call your parents. We'll sit down and we'll have a talk. Do you still need that cooker?
Yeah.
Okay. Okay.
The most recent surge of heroin abuse has altered our approach to addiction and our views on the war on drugs.
Cops and prosecutors and epidemiologists, public health nurses, county coroners. All of this is being fought by really anonymous folks all across the country because this epidemic is also the quietest epidemic. It's filled with shame.
Obvious overdose, known history of heroin use, admitted to using heroin today. He was found unconscious. They kind of roused him. They're going to start an IV on him.
You don't have a lot of violence. People die alone in a McDonald's bathroom toilet. And then when the people die, when the kids die, the parents are so mortified, so ashamed that they keep quiet too. And the thing is left to perpetrate and spread.
Okay, so we'll show you a couple more videos, and I want to reiterate that every jurisdiction is going to respond to this issue, to the opioid epidemic, to the mental health epidemic differently. I also want to reiterate that we're not trying to save individuals from consequences. If they break a law, there are consequences, but there are things we can do to intervene without slapping cuffs on them, right off the bat, throwing them in jail, only to do the same thing a week later. And I think regardless of what your view is on how to improve these situations, that what we've been doing hasn't been working. Overdoses continue to increase. Suicides continue to increase, especially among veterans, among first responders, among those who have some of the most traumatic jobs. Drug use continues to increase. Our supply gets deadlier and deadlier by the day. What we've been doing since this all started, really since heroin became an issue early in the 90s, it hasn't helped. There are things we've done along the way that may have paved the way for positive change, but we have a lot more steps to go. And I'd say in recent times, even within the last few years, I think we've really rounded a corner with this. But this can be a sensitive topic, and we're not wanting you guys to stop doing your jobs, to become 100% social workers, to not have the consequences be a reality, but it's the way we go about things and the extra piece of helping people. So just a little note from the former first responder and having worked with the police is, I think, just something important to keep in mind. All right, recovery story. We're gonna look at someone who made it out.
It is a reunion 5 years in the making. The last time Tiffany Hall saw Lieutenant Jim Foster, she was a drug addict with no future. Now she's about to graduate from college.
I want to thank Lieutenant Foster for his respect and his compassion and the empathy that he showed to me and anyone he came in contact with.
Tiffany credits Foster with helping to turn things around, even though he was often the one taking her to jail.
He would encourage me all the time. Tiffany, you can do better than this. Tiffany, why don't you try to go to school? Tiffany, why don't you stop?
For Lieutenant Jim Foster, seeing Tiffany's transformation is hard to measure with just words.
The biggest joy of my professional career is from time to time having contact with people who have found their way out of horrible circumstances and into life's success, things that a lot of us just take for granted for people who have a much rougher life story.
I tell myself every day, don't look back behind you because there's nothing back there. You got to keep looking forward.
The encouragement sunk in, and when Tiffany reached rock bottom, she finally decided to start listening to the man who spent so much time arresting her.
This is an announcement for her graduation. I wouldn't miss it for the world.
Tiffany graduates from college next month. She wants to become a social worker. She wants to give back the same type of hope and encouragement that Lieutenant Foster gave to her.
All right. I know those stories can kind of keep the motivation going, and keep in mind we do have success stories. Are they few and far between sometimes? But if we've touched one life, if we've help somebody get to where they need to be to succeed, we've done our job. Everything else is just a bonus. And if you ever need some extra recovery stories, I can certainly connect you with people that have succeeded if you know that that's what helps the motivation to work through these difficult calls and situations. So you can reach out to me if you ever need that. We have tons of people, staff members at TCN. We have members in the community who would be happy to speak with you and let you know that what you're doing is helping, and how you can continue to do that good work.
So just a little bit about harm reduction. Sometimes it's a word that's immediately spoken and maybe you cringe a little bit or are unfamiliar with what exactly harm reduction means. But essentially, harm reduction is just meeting people where they're at and trying to make sure that they stay the healthiest that they can in whatever capacity they define it as. And so with the harm reduction program at Greene County Public Health, we're kind of outside of the treatment realm, we're outside of the corrections realm, and outside of the medical realm. And so it's just that extra body of people that those that are struggling with mental health and addiction are able to go to, because maybe they have been stigmatized by all three of those entities and just need someone to reach out to for clean supplies, for referrals to different facilities, to treatment places, and then just some hygiene products and snacks if they need it. Ultimately, the goals of any harm reduction program is just keeping people safe and buying them time until they're ready to go seek treatment. So being kind of outside of those three different realms, we're in a unique position to be a non-judgmental entity that they feel safe at. So we provide different services for those that are in active use without the expectation that they stop using. We encourage treatment and recovery facilities, but we aren't forcing it upon them. And we provide the clean supplies. So ultimately, our goal at Safe Trade is to reduce the spread of communicable diseases such as HIV, hepatitis C, as well as a host of STDs that, come and follow along with IV drug use and just situations that can come with using substances. And so we're providing the clean supplies such as exchanging syringes and providing people that are in most need of Narcan and going to be around people that will be most at risk of overdose, providing them with Narcan as well as fentanyl test strips. We also give out xylazine test strips now with the increase in xylazine presence in the supply. And so we really try to prioritize what is going to keep them the healthiest as they define it. And so, like I said, providing just different hygiene things, referrals to different treatment facilities, and just transportation, getting them connected and signed up with Medicaid, or getting them connected with people so that they can go get an ID if that's what they need. So kind of a middleman that can get them to where they need to go.
Elena, what would you say to people who say harm reduction is enabling or is giving them an excuse to continue to use?
Harm reduction in general and safe trade is just, it's in our mind, it's another opportunity to interfere with someone and get them into treatment. So as I mentioned, if they don't feel comfortable or confident to reach out to the treatment facilities themselves, or they have a history with law enforcement that isn't positive, or anytime that they go to the emergency department, they are stigmatized, because we also do some wound care education and treatment, especially with xylazine present in the wounds that we're seeing with that. So I just example, someone that has come to Safe Trade since I have been working at it and since I think it started, someone that we would ask about treatment many times, almost every visit, would completely dismiss it. We have successfully gotten him into treatment. For him, it took getting out of the Greene County area, getting away from the negative influences of people that he has been with for the past several years. And he's now been, I think, almost upwards of half a year in recovery and doing very well. He likes to send us updates. And so for harm reduction, it's just a way to keep people as healthy as they can be so that they aren't getting infections, they aren't reusing dirty needles or someone else's needles, putting them at risk for other infectious diseases, and then that outside entity to kind of get them connected to treatment when they're ready.
So it sounds like harm reduction can be a means of like building that rapport, that connection that might take multiple visits to the exchange program, which eventually might lead somebody to like trusting you and being like, hey, maybe what you're saying is a good idea, like getting to treatment.
Yeah.
And then keeping the community as a whole healthy. Because if we have people using dirty syringes, continually overdosing, oftentimes that's more than just that person affected. It's like a whole domino effect.
Yeah, and there's a lot of what we've come to learn, some like secondary distribution. So maybe one person will come in and bring back supplies to a whole house full or apartment full of people. And so then them sharing the, I guess, non-judgmental space that we have, it then brings more people into our program that we are keeping healthy and safe with the safer use supplies. And then it's just increasing the interactions that we have with the population to get them into treatment.
Awesome. Well said. So going forward, like I said, we've made progress, especially recently, but in general, the past 10 years, if we look at them, how we've been combating these mental health and drug epidemics hasn't been as helpful as maybe we thought it would have been. And that's okay. This is something that the nation and the world hasn't ever dealt with. We're still learning. But more work still needs to be done to reduce stigma surrounding these issues. And these are some additional ways we can combat stigma. So using person-centered language. If you notice throughout this video, I didn't say addict or junkie, but I say person struggling with addiction, person who struggles with substance use, person who uses drugs. So using problem-centered language can perpetuate the self-fulfilling prophecy trap. So we're always wanting to put that person first, not assigning this all-encompassing negative label. That's who you are. You're an addict. You're a junkie. That's all you're good for. Because people who struggle with substance use, that's all they hear. And sometimes they don't realize that's all they hear. And I often see people go into this self-sabotaging spiral that takes a lot of therapy to get them out of. Building your knowledge. I'm of the mindset that knowledge equals power. It can give us it can put us ahead of a lot of things. It can bring us a lot of closure. And just spreading knowledge, awareness of resources, communicating with people, all these things can really help put us ahead of the game. And if there's anything that Greene County's been good at, it's getting ahead of the game, in my opinion. We have a lot of flagship programs within our public safety realm, within behavioral health, even in our public health realm. We've had a lot of these innovative programs. And so staying ahead of the curve is, I think if we keep doing that, we can really make some positive change. And yeah, just know who your resources are. Like I said, you don't have to be the resource expert. Just know how to get them to me, know how to get them to a therapist, know who the people are, who are your middlemans. Public health is one of your best resources here in Greene County. And the good thing is public health is embedded in every county. So you've got public health no matter where you're at or where you're watching this from. And like I said, communicate. So, if you have a partner that you're on scene with and they're maybe more naive to things that you are, just being empathetic and being like, look, hey, we've got this resource, maybe next call we do that looks like this, we can do this instead of that. Taking this curious but empathetic approach and getting them to the right people, that way you don't have to manage this on your own anymore, is really what's gonna continue helping us make steps in the right direction.
Kind of wrapping everything up and reviewing what we've all talked about, just defining stigma, the thinking or acting negatively towards another person or group of people based on an identifiable characteristic, trait, or affiliation. We talked about the 6 components of stigma: the labeling, stereotyping, cognitive separation, emotional reactions, status loss and discrimination, and power. And then just recognizing the signs of stigma, stigmatizing language, and knowing how to reflect on that and then kind of change some behaviors and thought processes. And I think that's ultimately, like, the goal of this training is not punitive. We're not trying to be accusatory towards anyone, but more so, as Nicole mentioned, like, just increasing our education and awareness of the issue, because sometimes if you don't acknowledge that it is an issue, it's never going to be improved upon or changed. Ultimately, gave you some tools of how to reduce stigma using the person first language, obtaining and spreading awareness, and then just attending and listening to trainings like these, and referring them to your peers and other members in the community. These are just some of the references of the information and videos. And then we have our post test, if you wouldn't mind scanning that with your phone and taking that. We appreciate your time and attention, and please provide us any feedback. We're happy to adapt and make this more applicable to however you see fit. So we appreciate your time.
Yep. Thank you guys. Take care and be safe.